So good morning, everyone.
My name is Philip Seo, and I am the Program Director for Johns Hopkins Rheumatology. My co-moderator is Dr. Elena Kruzman, who is a Rheumatology Fellow at the Hospital for Special Surgery in New York. On behalf of my co-moderator and the American College of Rheumatology, I want to welcome you to this third lecture from the Virtual Rheumatology Learning Collaborative lecture series. You are now in a virtual lecture hall with hundreds of attendees. I'm sure that number will just continue to grow over the next several weeks. Just a few housekeeping issues before we start. The chat function at the bottom of your screen is used for general comments. If you're having an issue with the system, please use the raise your hand function. Finally, if you have a question for the speaker, please use the Q&A function. My co-moderator and I will be reviewing your questions during the presentation, and we will try to get to as many as possible. Finally, it is a great pleasure to introduce someone who truly needs no introduction. Michelle Petri is the co-director of the Hopkins Lupus Center, and she will be speaking to us on lupus and the data behind Plaquenil. Michelle, thanks so much for coming this morning.
Thank you, Phil, and thank you to the American College of Rheumatology. Here are my disclosures. I always like to start with the autoimmune pyramid. And down at the bottom, you see autoimmune serologies. This is so important because it turns out about 20% of normal young women have a positive ANA. And that's why we can never depend on the ANA to make either a classification or a diagnosis of lupus. Just above that, I have localized autoimmune disorders. These are so common. One of the most common ones is autoimmune thyroid disease. And it turns out that 50% of patients with autoimmune thyroid disease also have a positive ANA. Now we're finally going to get to the point where rheumatologists get involved with undifferentiated connective tissue disease. That is not rare either, and it's actually thanks to lawyers that we have an idea what its prevalence is. This goes way back to the silicone breast implant controversy, and finally, when case control studies were done, it turned out that 5% of control women who had never had a silicone breast implant met classification criteria for UCTD. Now, of course, I'm biased. I'm the lupus lady, so I put SLE at the top of this pyramid. But obviously, SLE is not the most common systemic autoimmune disease. I wanted to talk about classification criteria. You're probably already aware that EULAR and ACR have their own set of classification criteria now. Their criteria are different from previous ones in that they require an entry criterion that the ANA must be 1 to 80 or higher. And the other criteria are weighted. I wanted to show you the slick revision of the original ACR classification criteria because it did two unique things. The first is that if the patient had lupus nephritis by biopsy, you didn't need to add up to 4 criteria. Lupus nephritis alone was sufficient to classify as SLE. The second thing that was unique was to make it very clear that lupus classification required both clinical manifestations and immunologic tests. So at least one of each, adding up to a total of 4. And here you see in front of you the clinical manifestations. And you see that the first 4 are cutaneous because the skin is such an important part of identifying lupus. The next 4 are 4 other organ systems. So joints, serositis, renal if a biopsy was not done, neurologic, greatly increasing the number of criteria that had been in the old ACR set, so no longer limited to seizures and psychosis. And the last 3 are the 3 different cell lines that can be affected by lupus. In the old ACR criteria, they were all combined into 1. but the regression modeling done to come up with the SLIC criteria showed that they track individually. Now remember, you have to have at least one of these and at least one from the immunology list. And yes, ANA is there. And in the SLIC criteria, we did not require that it be 1 to 80 or higher. But I guess even more importantly, when you want to contrast these with the EULAR-ACR criteria, is that an ANA is not necessary in SLIC to classify as lupus. And this is because about 8 to 10% of patients who are classified as lupus by experts are ANA negative. And by the way, this can even include lupus nephritis. Now for anti-DNA, because the ELISA assays have a gray zone, the anti-DNA must be twice higher than the laboratory reference range to count. Of course, anti-SM. I love the anti-SM story, by the way. When Morris Reichland was naming these autoantibodies that he was discovering in lupus sera, he named them after his patients. So this came from a patient named Smith. And I know it's not HIPAA compliant, but you know, what a wonderful way to acknowledge how important patients are in our research. Now, next are antiphospholipid antibodies, and they're all listed here. In particular, SLIC allows all isotypes. And I wanted to remind you that in lupus, the most common isotype of anti-beta-2 glycoprotein is IgA. Now for anticardiolipin is not that rare in the general population, so we've said it must be twice normal or medium to high titer. Low complement is there. Low complement had been left out of the original ACR criteria, but of course is part of the EULAR-ACR criteria. And then the direct Coombs test. Of course it's an autoantibody, and you know it's very specific for lupus, but what you may not know is that 90% of lupus patients who have a positive direct Coombs test will never manifest a hemolytic anemia. I wanted to do a little visual show and tell because so much of lupus is understanding the dermatologic signs. And I want to start with this. This is one of those classic slides, classic photos. I've always asked, why is this patient smiling? Because can you imagine how devastating it is to have a rash like this? Now this, of course, is the malar rash of lupus, sometimes called the butterfly rash. I hate to call it the butterfly rash because rarely is it classic like this. In most patients, you'll see a little rash, and sometimes above the lateral eyebrow and the lateral cheeks, which may get more sun exposure, for example, than front on the face, especially when someone's in a car, for example. But the key points to a lupus rash is you have to ask the patient questions if they're not manifesting the rash right in front of you. And the first question is, when did the rash occur in conjunction with the sun exposure? Lupus rashes don't occur the first day. There are rashes that do occur almost immediately after sun exposure, and that will be solar urticaria, itchy bumps, polymorphous light eruption. Now, your second question is, how long does the rash last? Because lupus rashes are due to inflammation, they are not transient. They will last for days to many weeks before they resolve. And your third question to the patient, is it raised? Again, because these are inflammatory rashes, they will have texture to them. And looking at this photo, you can tell that this patient has raised lesions. Now, also very important on this photo is the areas that are shaded from ultraviolet light don't have the rash. You know, dermatomyositis rashes look very much like lupus rashes on histopathology. There are examples of interface dermatitis, but a dermatomyositis rash will occur in the nasolabial folds, which may be helpful. Now, I call this, if you have a 50% chance of getting it right, you need to play along and guess. So, which of these two photos is a patient with lupus alopecia? Now, I hope you guessed the patient on the left, and not the one on the right. The one on the right is an example of one of those localized autoimmune disorders, alopecia areata, which is separate from lupus. It's not a lupus manifestation. The lady on the right shows the classic findings of lupus alopecia. The hair is thinner than normal, so the scalp shows through, and it's more fragile than normal, so it breaks off on areas that get more combing and brushing, such as around the frame of the face. Now, I know patients frequently say they have hair fall. Hair fall is a subjective symptom. There is nothing on the SLIC criteria or the EULAR-ACR criteria that involves subjectivity. You use your physical exam to determine if the patient has lupus alopecia. Now here is the most devastating lupus rash. This, of course, is discoid, sometimes called chronic cutaneous lupus. This involves the deeper areas of the dermis, and when it heals like a first-degree burn with hypo and hyperpigmentation. So those light pink areas, those actually don't represent activity. That's part of the scarring process. The active lesions are the ones you see which are eroded and have scale over them. And you can get an idea about how photosensitive this rash truly is by the fact that you see it inside of the ear, where it must be really hard to get a lot of ultraviolet exposure. This is terrible, of course, because this occurs often for months before the patient is diagnosed with lupus, which delays therapy. It's more common in smokers and much more common in African Americans. Now, when you look at this slide, you're going to say, okay, this is rheumatoid arthritis. But of course, lupus and rheumatoid arthritis affect the same distribution of joints. I often will insist that this be part of a note. I want to know, does the arthralgia occur in a connective tissue disease distribution? Here, of course, you can see there's more than arthralgia. I think you can appreciate that there's MCP synovitis here. But what you may be paying most attention to are the deformities. Now, how do I know this is lupus? I cannot know unless we reach into this slide and we show that we can straighten these deformities. That is the definition of Jacquard's arthropathy. So what looks like a swan neck deformity and a Z deformity of the thumb are reducible. By the way, this also happens in the feet. You must look at the feet. You must undress the patient. Now, we can't do that anymore, can we, with telemedicine? I call telemedicine medieval rheumatology. But back when we could examine patients, how important it was to be able to show this. Now, this is not due to erosion. This is due to tendon and ligament laxity. How does this happen? Well, it happens because we miss the tenosynovitis at the very beginning of the diagnosis of the patient. And so we miss a chance to be more aggressive to get that under better control. I think eventually when ultrasound is used routinely in the management of lupus, we may be able to pick up this tenosynovitis so that we prevent later Jacquard's arthropathy. Now let's go back to the basics. What causes lupus? I thought you'd like this cartoon. Figuring out the human genome map was easy. The hard part is refolding it. So here's one of the classic GWAS studies. Lupus is 50% genetic predisposition. Now, of course, HLA swamps everything else. Most lupus patients will have an HLA predisposition that just gives them a more active immune response. But you see here also some clues to B cells, some clues to the interferon pathway, and some clues to intracellular signaling. You see STAT4 there. A whopping 70 to 75% of patients in clinical trials for lupus have the interferon gene signature. In our outpatient practices, though, it's more like 50%. But these kinds of GWAS studies confirm the importance of the interferon pathway in the pathogenesis of lupus. Now, I don't want you to think that these are mutated genes. It's actually very rare to have a Mendelian inheritance of lupus. What happens is that these are genes that everybody in the population might have that cause a pathway to be more active. There are huge ethnic differences in lupus. The CDC has funded more recent studies that have updated incidence and prevalence and have included other important ethnic groups, including Hispanic Americans, Asian Americans, and American Indians. But I wanted to show you these classic studies. The third one was Mark Hochberg when he was at Hopkins. And what these initial studies pointed out was the huge increase in African Americans or African Caribbeans. The fourth study is actually a study in London. So where you see Asians having an increased incidence, they actually meant South Asia, India, Pakistan, Bangladesh. Now, if SLE is 1/2 genetic predisposition, it follows it must be 1/2 environmental. Ultraviolet light is one of the key precipitants. It's not just UVA, it's also UVB, it's both. And so you have to have a sunblock that will block both. I am very strict about this. So if a lupus patient comes in with a flare of rash, my first question to them is, where is your hat? Because just walking from our outpatient garage into our clinic center is actually enough ultraviolet exposure to activate lupus. And my second question, of course, is where is your sunscreen? Because sunscreens are not effective if applied just once a day. Now, secondly, here you see drugs or supplements. You may have memorized the list for drug-induced lupus. Those are things like isoniazid, procainamide, hydralazine. Actually, some much more important ones nowadays. Minocycline has been a major cause of drug-induced lupus that may actually confuse people because it can present with a hepatitis and ANCA. But of course, rheumatologists can cause a biologic-induced lupus as a very rare adverse event with anti-TNF therapy. Those things are not what I want to emphasize. I want to emphasize the drugs and supplements that are environmental precipitants for systemic lupus. And Bactrim, trimethoprim sulfa, is one of the oldest culprits. By the way, that was just discovered by Marion Ropes, a rheumatologist at Mass General, back in the early 1950s when the sulfa antibiotics were first introduced. And she discovered it just by being a good clinician. It's in her monograph, which is a wonderful historical document to read. I loved her because she always insisted that her clothes had to have pockets because she was too busy a lady to carry around a purse. Now, echinacea is another precipitant, and I learned this the hard way from my patients who decided to take it because they thought they wanted to boost their immune system every day, and instead of just taking it when they had a cold. And I had several patients hospitalized with lupus nephritis flares from doing that. Now, I mentioned already that smoking is a risk factor for discoid lupus, but smoking is a risk factor for lupus in general. I will talk about infections on the next slide. I wanted to mention, though, that there are environmental pollutants, which also are problems in inducing lupus, and those are silica, mercury, and pesticides. Now, here is the infection story. And this is wonderful work that came from the laboratories of Judith James and John Harley at the Oklahoma Medical Research Foundation. They showed in multi-case families that the children in those families that had lupus had an astronomically high association with Epstein-Barr virus. That p-value is 10 to the minus 11th. Now, you know that 90% of adults in the general population have had EB virus, but in these multi-case families, the adults still managed to have a higher association with EB virus if they had lupus. This group then went on to show in the military serorepository that EB virus occurred first, way before there were lupus autoantibodies. Now, we certainly don't think EB virus is the only precipitant of lupus. There's evidence that CMV, perhaps even parvovirus, and viruses we haven't yet discovered may be precipitants. Now, how does lupus start? Well, here I want to acknowledge this seminal paper from the laboratory of Dr. Cassiola Rosen and Dr. Rosen. Dr. Rosen is the chief of rheumatology at Hopkins. Their research laboratory showed that apoptosis is the key. What you see here on the right is an apoptotic cell. You can see the chromatin coalescing, and outside the cell, those very small bodies, those are the apoptotic bodies. All the proteins to which lupus patients mount autoantibodies are presented to the immune system in those apoptotic bodies. Sometimes people like to call this the garbage disposal hypothesis of lupus. In you or in me, we have millions of cells undergoing apoptosis all the time. Our macrophages gobble up these dying cells in a non-inflammatory way. But in someone destined to have lupus, the macrophages digest these cells in a pro-inflammatory way, making pro-inflammatory cytokines like TNF-alpha that start the process towards break-in tolerance. Then there is probably a feed-forward loop. So I want to walk you through this. On the left, you see B cells. And of course, in lupus, the B cells are making autoantibodies that bind to the self-antigen. This then activates the toll-like receptors in the plasmacytoid dendritic cells. Plasmacytoid dendritic cells are one of the major sources of interferon alpha. And we've already discussed that in lupus, 50% of our outpatients and 75% of clinical trial patients have this interferon alpha gene signature. When interferon alpha is there all the time, it's going to lead to maturation of myeloid dendritic cells, monocytes, macrophages. That's important in two ways. Let's close the first circle first. BAFF, or the B lymphocyte stimulator protein, comes from the myeloid cells, and it's an essential growth factor for autoimmune B cells. But now let's close the lower circle. Macrophages, of course, present antigen, in this case self-antigen, to T cells. And as you know, there's too much T help in lupus, keeping B cells active, and too little of the T regulatory function. Now, B cells also do other things besides making autoantibodies. They make cytokines and chemokines. They're involved in lymphoid organization and migration to target organs. You see that both the innate and the adaptive immune system are crucial here, and the involvement of the innate system is not limited to plasmacytoid dendritic cells. In lupus patients, there can also be a neutrophil gene signature. There can be too much netosis. And these self-antigens can get caught in those nets. That can lead to an increase in interferon and an increase in the adaptive immune system as well. Now, I put X's in some of the places where we might want to try to interrupt this. And you can see that big X by B cells. Of course, we can interrupt B cells through cytoxan or rituximab. You see the big X between B cells and BAFF. That's our one approved biologic, belimumab. And then some potential areas are the other X's. What is it like to be a patient with lupus? Here you see a patient with a flare pattern. On the left, you see the physician global assessment. You can see how many flares this patient has. An average patient has about one a year. This patient is worse than average. On the right, you can see the same pattern can be mirrored using a more complicated instrument, the SLE Disease Activity Index. The SLE Disease Activity Index is a very simple one where you just check whether a manifestation is present or absent, and you then multiply it by its weight. For example, arthritis is multiplied by 4, skin rash is multiplied by 2. And I was teaching this to a fellow one afternoon in clinic, and the patient, of course, was there. I think patients usually love when we teach because they're learning too. And all of a sudden, the patient interrupted, and she said, "Dr. Petri." So I figured I must be in trouble. And I turned to her and I said, "Is something wrong?" And she said, "Dr. Petri, you never told me you knew when I was going to die. And it's because I called the instrument the SLE dye." And so from that day onward, I renamed this instrument. It's now called the SLE day, D-A-Y. It's how active her lupus was on that day. Now, when you listen to one of my talks, there are always going to be a couple of important take-home messages. Here's one of the most important. Prednisone is poison. Now, I know it works. I know it works fast. I know that even in this era, we have to use it. And of course, I'm so worried with the shortage of hydroxychloroquine that as patients run out or have to ration it, we may end up using more prednisone rather than less. So how did I decide prednisone was poison? I truly believe in longitudinal research. That's what I do. I run a lupus cohort where patients are seen by protocol, and we record the disease activity, the treatments at every single protocol visit. And here is our longitudinal analysis of how prednisone leads to organ damage. And this is a sophisticated longitudinal regression analysis that adjusts for confounding by indication. Because of course, there's a reason we gave prednisone. It was due to how active the lupus was. And what we found is that we should be redefining high-dose prednisone as anything 6 milligrams or above. Because if you've maintained your patient on 6 milligrams or above, you've already increased permanent organ damage by 50%. You can see the hazard ratio when you get above 18, there's over a 2.5-fold increase. Now, I circled what I would call the acceptable range. Now, by the way, there's still a 16% increase in organ damage, even if you keep the maintenance prednisone dose below 6. But please remember how important accelerated atherosclerosis and cardiovascular events are in our lupus patients. So one of my most important analyses done with our biostatistician, Larry Magder, was this one. Now again, these are sophisticated analyses. They adjust for the disease activity and they adjust for all the traditional cardiovascular risk factors. What this proves is a dose response for prednisone as an independent risk factor for a cardiovascular event. You can see the risk at 10 milligrams is increased 2.4-fold, and at 20 milligrams is increased 5.1-fold. Now, what do I do if the patient comes in with a mild to moderate flare? I'm not going to say to the patient, "I'm sorry, I so hate prednisone that I refuse to treat your mild moderate flare. Go home and suffer." So of course I had to find a way out of this dilemma. So the great majority of mild to moderate lupus flares can be treated by a triamcinolone intramuscular injection in the buttock. We use 100 milligrams. And in this era of medieval rheumatology, we would give a Medrol dose pack, which probably works just as well. Now, obviously, this is not going to be sufficient for major organ involvement. What are our current treatment approaches? Well, I want hydroxychloroquine to be for all lupus patients as background therapy. Back when it was called Plaquenil, I used to tell my audiences that the P in Petri stood for Plaquenil. It does so many good things. Very importantly, it reduces flares by 50%. It reduces organ damage. It reduces lipids. In antiphospholipid positive patients, it reduces the risk of thrombosis by 50%. In patients with lupus nephritis, it triples the complete remission rate on mycophenolate. And it is the only drug that has been proven in multiple studies to improve survival. Now, I hope it isn't a shock to you that our patients don't always take their medications. And in fact, when we introduced hydroxychloroquine blood levels into our routine practice, we found that 50% of my own personal patients had subtherapeutic or even 0 levels. One of my favorite stories came from Natalie Kostodoit, who pioneered using hydroxychloroquine blood levels in her practice in Paris. She looked at the patients she had admitted to hospital with severe lupus flares and found that 50% had 0 levels. And it turned out that these 50% had kept all of their ophthalmology screening visits. Can you imagine, what a tangled web they weave? Because they were going to the monitoring visits when they weren't taking the medication. Now I know everyone is very interested in what potential treatments we may eventually have for COVID. There is actually a very long backstory to antiviral mechanisms for hydroxychloroquine. There was even a study decades ago that it might have an antiretrovirus effect for HIV, but of course much better therapies were invented for HIV, so it was never seriously considered. But in the case of COVID, it might prevent the entry of COVID into the cytoplasm. It is an immunomodulator. Now, it's not immunosuppressive. In lupus patients, it has never been shown to increase the risk of infection. But remember its effect on plasmacytoid dendritic cells, which of course are a major producer of interferon. So it might have an anti-interferon effect in COVID. Now you're going to say, well, maybe that would be bad. But maybe later in the disease course, it might be good to avoid cytokine storm. We don't know. We don't have those data. And then through inhibition of MAP kinase, it might be able to reduce viral replication. Now remember, these are potential or hypothesized mechanisms, and I've even mentioned that one of them might be bad for COVID. So what are the data? Well, right now, there are some interesting in vitro data, and I want to particularly thank Max Koenig and Andrea Fava, 2 of our fellows who helped in the development of these slides. And what you see here in the middle with chloroquine and on the right with hydroxychloroquine is evidence in vitro that antimalarials might be able to trap COVID in the early endosomes. This goes back to the very basic mechanism of antimalarials. They affect the pH in lysosomes. Now here's another study that suggests inhibition of viral replication for both treatment, but also for prophylaxis. But this is just in vitro. I think you're aware that there is a study underway for prophylaxis and treatment in the United States, and we hope there'll be more information from Italy and France who are ahead of us in the curve and may have had more chance to gather such data. Now, what about the clinical trials that are out there? Our problem is that when you're in a war, it is very hard to do good quality clinical studies. And you can see from those big red circles on the right, the studies that have been done to date that suggested some benefit are poor in quality. And one of the studies suggested no benefit whatsoever. So we can't reach any conclusions from what is now available. And you can understand why Dr. Fauci actually referred to these data as anecdotal. So here's the study that got the most press, suggesting that hydroxychloroquine had some benefit and hydroxychloroquine plus azithromycin had even more benefit. And this brought up this issue, does hydroxychloroquine cause a long QT syndrome, and could that lead to major toxicity? I've never once had this happen in a lupus patient, but if you start to combine medications that affect the QT, I think all bets are off. I don't know. But I wanted to dissect out the reason why you should not depend on that study. It didn't do an intention to treat design. And all the patients in the hydroxychloroquine arm that did badly were not included. And that included the patients who had to go to the ICU and the patient who died. So who knows what the true story was if you did intention to treat. Now let's get back to our clinical use. We know that hydroxychloroquine can induce retinopathy. And here's the test we should all be making sure our ophthalmologists order for our patients once a year. At the top, you see the parafoveal region when it is normal. There's that nice dip. And can you see at the bottom? That dip is gone. And instead, inside of the dip, you see what is called the flying saucer sign, which I think showed in a wonderful way that ophthalmologists have a sense of humor. But it means that you and I could read OCTs, couldn't we? We can see the hydroxychloroquine retinopathy here. But there's been a huge scare. And this came from a retrospective study from Kaiser Permanente. This suggested that hydroxychloroquine retinopathy was much more common than we used to tell our patients, and that this was such a problem, this led to the American Academy of Ophthalmologists to change their guidance. Now, I agree entirely with their guidance that this OCT test, along with visual field, should be done at baseline 5 years and then every year. Yes, absolutely. We can pick this up when patients are completely asymptomatic and then they won't have any visual damage. But I'm not happy with their dosing recommendations. So they have decided that everyone must be dosed at less than or equal to 5 milligrams per kilogram. Now, of course, we should always be reducing dose if the patient has renal impairment or hepatic impairment, and we should always be reducing dose in the elderly. But this was across the board in everyone. I prefer the hydroxychloroquine blood level approach, where you dose based on whether the hydroxychloroquine blood level is in the therapeutic range. We have published that patients that have high levels of hydroxychloroquine in the blood now, not plasma, it must be blood, are at greater risk for retinopathy. So when those patients are identified, I recommend reducing the blood level so it's in the therapeutic dose but not high. Now, a second immunomodulator that I want you to use routinely is in your patients whose 25-hydroxy vitamin D level is below 40. I recommend adding vitamin D. And it's based on this longitudinal study that we did, that vitamin D achieving a level of 40 helps global disease activity, and as you see circled in red, helps the urine protein to creatinine ratio. Now, vitamin D is very interesting. It's a hormone. It should never have been called a vitamin. It may also retard fibrosis. That's been shown in experimental models of pulmonary fibrosis, for example. It may even retard renal fibrosis, but we need much better human data. So I really like this immunomodulator because we can use it very safely. It's never necessary to get high levels. We just want to achieve 40. Normally, we can do that by getting 50,000 international units once a week. If someone's very obese, it has to be twice a week, not subsequent nights. It must be separated in time, like Sunday and Wednesday. And if your patient were to stop it, they will almost automatically plummet again to a low level. That's because it's the pro-inflammatory cytokines that drive it down. Vitamin D has so many other interesting effects. It may have cardiovascular and hematologic benefits. We've been able to prove, for example, that it lowers many cardiovascular risk factors, things like blood pressure, cholesterol. But I'm particularly interested in its use also in antiphospholipid positive patients. In the general population, vitamin D has been proven to reduce thrombosis, including in a randomized clinical trial of cancer patients that you see in the top bullet, the very highest class of evidence. There's also been an association of low vitamin D shown with cardiovascular events and venous thrombosis in cohort studies. We know in antiphospholipid that vitamin D can reduce tissue factor. Now, over 50% of my patients are on immunosuppression, meaning hydroxychloroquine and vitamin D together are not sufficient. So what are our immunosuppressive drugs? On this list, the only thing that is FDA approved is belimumab. We tend to pick our immunosuppression to match the organ. So mycophenolate mofetil, as you know, is predominantly used for lupus nephritis. We rarely use cyclophosphamide anymore. Please remember that mycophenolate mofetil is superior to cyclophosphamide in African Americans. Mycophenolate also works for cutaneous lupus. It also works for serositis. It's not the world's best joint drug. For joints, we predominantly use methotrexate, sometimes use leflunomide. Remember, for pregnancy, we use azathioprine. Azathioprine also works for other organ manifestations in patients who have unacceptable toxicity to mycophenolate or methotrexate. In terms of biologics, yes, we use rituximab. And of course, we have to face the fact that the clinical trials were negative. The clinical trial for lupus nephritis called LUNAR did not show any benefit above mycophenolate, and the clinical trial for non-renal lupus called EXPLORER did not show any benefit above our standard of care. But the EXPLORER trial was really top-heavy in prednisone. That may have killed its study design. So when do I think we should be considering rituximab? In the acute situations, I use it for thrombocytopenia, hemolytic anemia, pulmonary lupus, meaning lupus pneumonitis. I use it for catastrophic antiphospholipid syndrome. And for the more chronic patients, I use it for lupus arthritis when methotrexate, leflunomide, for example, are not helping, because we do not want to use anti-TNF for lupus arthritis. Anti-TNF can induce anti-DNA and can induce antiphospholipid antibodies. Now, belimumab has been around for a while, so we now have really good long-term studies that show a great long-term safety profile with no new safety signals. And Murray Urwitz did a fascinating study comparing the belimumab open-label patients to his Toronto cohort patients using propensity matching that showed the belimumab open-label patients accrued less organ damage than the Toronto cohort patients who were achieving, state-of-the-art care at an academic level. So those are very powerful and important studies. But I did want to go back and show you the basics for belimumab. Here you see the phase 3, and it's very clear that the subgroup with both high anti-double-stranded DNA and low complement has the greatest delta over standard of care. So it's the serologically active subsets with active disease requiring prednisone. Those are the patients who respond best to belimumab. I want to thank Rich Fury, who developed this slide and the next slide. I wanted to show you what's going to hopefully come next for non-renal lupus. I want to show you the anifrolumab data. And this is the anti-interferon alpha approach, but this is anti-interferon alpha receptor blocker. MUSE was the phase 2 study. SRI is the Systemic Lupus Responder Index. BICLA is a responder index based on the BILAG. And you see they both showed a really great delta, both agreed with each other. Very promising phase 2. The phase 3, though, has been schizophrenic. TULIP 1 did not show any significant benefit for the SRI. TULIP 2 looks much more like MUSE, with benefit for both SRI and BICLA. You can see how well they agree. And by the way, the SRI and BICLA should agree. The difference with SRI is that since it's based on the SLEDAI, the only way to lose points is if an organ manifestation resolves. BICLA allows capturing partial improvement. So I've shown all three here, or Rich has shown all three here. The FDA will have to make the decision of whether this gets approved. I'm in favor of approval because I think we need to look at the totality of the evidence and the fact that in these clinical trials, there's been very powerful data to suggest it works quite well for skin. Now, what's coming down the road for renal lupus? First, calcineurin inhibitors. And of course, we already have data that tacrolimus can be added on top of mycophenolate with acceptable safety and much better efficacy. That's called the multi-target approach. Voclosporin is the next generation calcineurin inhibitor. You don't actually have to measure, peak and trough, that kind of stuff. And you see the great efficacy in the voclosporin phase 3 trial without the safety signal of deaths that plagued the phase 2. The belimumab renal trial has only been announced in a very short press statement, so we're all looking forward to seeing more data on that. Obinutuzumab is the next generation rituximab. It is a better B-cell depleter. And you can see the excellent results in the fact that it went out to 76 weeks as well. Now, prognosis is not so great in lupus, is it? But you're going to say, oh, it's gotten much better. Why is 1978 the last year on our slide? Well, it turns out the survival of lupus patients plateaued in 1980. Lupus patients don't tend to die from lupus. You know, they die from cardiovascular disease and infection. The risk of cardiovascular disease has increased 2.66-fold. And even if we did adjust for all the traditional cardiovascular risk factors, this wonderful Canadian study showed that there's a huge leftover risk. Let's call that the lupus risk, you know, over 8-fold increased risk of myocardial infarction, for example. So what can you and I do to reduce the risk in our current patients? Well, you must assess and treat all the traditional cardiovascular risk factors to target. You should hear me in my clinic. I know in the general population you think the goal is 130, but please don't forget the SPRINT study, which showed even in the general population, the goal should be 120 systolic. In our longitudinal research, definitely the goal should be 120. So if my lupus patient has a blood pressure of above 120, I'm interrupted no matter what I'm doing by our CMA. And then I go and talk to the patient and I want to find out, you know, are they taking their antihypertensive? I don't accept excuses. I don't accept the most common excuse, which was, Dr. Petri, I was rushing, so I wouldn't be late for your appointment. And I say, I'd rather have you late than take your blood pressure medicine. And please, you know, be very careful about this because hypertension is one of the major risk factors. And of course, we want patients to meet all their other targets, and we recognize obesity and smoking are the hardest ones for our patients. Please remember that hydroxychloroquine helps hyperlipidemia. So does vitamin D. Vitamin D helps hypertension. So some of our immunomodulators are going to help us in our efforts to control traditional cardiovascular risk factors. Now, perhaps you've decided that the answer is statins. You know, if you had met me 10 years ago, I would have agreed with you. I so thought statins were the answer that I did an investigator-initiated trial of a high dose of atorvastatin versus placebo. And it was the world's most negative trial. It did nothing for any measure of atherosclerosis, carotid plaque, carotid IMT, coronary CT score, nothing. Now, it did lower cholesterol, but nothing in terms of reducing cardiovascular risk of lupus. And the pediatricians did a very similar trial, again, a negative trial. But the final nail in the coffin for statins was they don't even work in murine models of lupus. So of course, if your patient is hyperlipidemic and lifestyle changes have not helped, you would add a statin, but it's not going to help other lupus patients. So what does help? It turns out in the mouse model, mycophenolate helps. And Karen Kostenbader has found that mycophenolate probably helps more than azathioprine in lupus patients, but we can't give mycophenolate to all our lupus patients, can we? Because it has real risks. You remember all those boxed warnings? Please, when you start someone on mycophenolate, make absolutely sure you do the risk evaluation management strategy developed by the FDA. You just Google REMS, you click on mycophenolate, you print it out, you have the patient read it and sign it. It reminds them never to become pregnant. 25% risk of major fetal malformation, and that mycophenolate interferes with the efficacy of oral contraceptives. The other box warnings are the things you know about: major infections, PML, non-Hodgkin's lymphoma, all malignancy. So we cannot give this to all lupus patients. But doesn't it give you hope that someday we will have some sort of immunomodulator that will retard this process? And of course, you'll remember my prednisone slide. If you are allowing a patient to be on a maintenance dose of prednisone greater than 10 milligrams, you are contributing to this risk. Now, how is lupus doing this? Using our longitudinal data, we developed the cardiovascular risk equation. You can see all those traditional cardiovascular risk factors But you see the last three? These are the lupus-specific risk factors that are independent risk factors for a cardiovascular event. The SLEDAI per unit increase, lupus anticoagulant, and low C3. Now, any of you who are SLEDAI experts will know low complement is part of the SLEDAI. SLEDAI is so important that it appears almost twice in this equation. So what you and I need to know if we're going to get rid of atherosclerosis in lupus patients is the SLEDAI has to be 0. We must prevent the lupus anticoagulant from leading to thrombosis, and we must normalize the C3. All of you know we can't do that right now. Sort of the aim in practice right now should be the lupus low disease activity state, which is prednisone less than or equal to 7.5, SLEDAI less than 4, physician global less than 1. Being on hydroxychloroquine immunosuppressants is fine, but no flare and no major organ involvement. Now, I would be remiss, wouldn't I, if I didn't talk about lupus from the patient's point of view. Universally, the major lupus patient complaint is fatigue. This is so common, but our problem has been that the chronic fatigue that our patients tell us about does not correlate with disease activity as we can measure it. Instead, it correlates with the fibromyalgia spectrum, pain, depression, sleep problems for quality of life, and it's also associated with reduced physical fitness. I so love the recent paper from David Pazetsky's group, where he has now relabeled the symptomatology of lupus into type 1, those are the things you and I measure, rash, arthritis, nephritis, and type 2, which are the patient-reported things that you see on this slide. So instead of saying to patients, that's not your lupus, we can start to say, you're having type 2 symptoms. Our current lupus medications don't help type 2 symptoms, so we are going to take a different approach. So in this way, we validate what the patients are telling us, and they don't think that we're ignoring their quality of life. Now, what can we offer? I want to remind you about a wonderful clinical trial that showed how effective exercise was for SLE-related fatigue. And I like to summarize this to patients. You know, it's over 80% effective. You need to do this because patients who are fatigued tend to rest even more. It's counterproductive. We need patients to have an exercise program for their cardiovascular health as well as to help their fatigue. Now, I'd like to end with this beautiful painting by El Greco of St. Sebastian. And now you're going to say, well, this is a female predominant disease. Why is she picking a painting of a male saint? Well, it's because although lupus is only 10% male, our male patients have the worst prognosis, the highest mortality, the greatest end-stage renal disease, and the greatest amount of myocardial infarction. But I wanted to have this slide be our final thoughts because lupus patients don't die from one arrow. They die because there's so many arrows. You know, of course, there's lupus nephritis, there's atherosclerosis, there's infection. It just goes on and on and on, doesn't it? So I've always thought that the lupus doctor is the primary care doctor for our patients. Thank you, and let's open it up for questions.
Michelle, thank you so much for that great talk. It's always enlightening to listen to you. We have been reviewing, as you may imagine, a number of questions that have been asked online, and Dr. Kruzman is going to get us started.
Thank you very much, Dr. Petri, for this very informative and wonderful talk. So a lot of questions. One of them is, how do you approach Bactrim prophylaxis in patients with lupus, given the risk for flares with this medication?
So for PCP prophylaxis, I prefer using dapsone. Now, you remember the rule for dapsone, you must check the G6PD first. And then we have followed our oncology center's protocol to give dapsone 100 milligrams Monday, Wednesday, Friday. And of course, quick taper of prednisone.
Thank you. Now, switching gears, so with respect to hydroxychloroquine levels, so in your clinical practice, how do you approach assessing hydroxychloroquine levels? How frequently do you check? you said you adjust your dose based on the level. Do you ever go above 400 milligrams per day? And how do you define a therapeutic level of Plaquenil?
Hydroxychloroquine blood levels are not yet available everywhere. They've been available at Hopkins for the last 7 years. They're available at Quest. I've been told by LabCorp that they're going to introduce them hopefully this summer. Mm-hmm. Every lab may have their own therapeutic level. So I want to mention that Hopkins levels may not necessarily generalize. Please don't use plasma levels. Plasma levels don't reflect what the patient's been taking for the last month. That's the great advantage of the blood levels. So start out by measuring hydroxychloroquine blood levels to identify your patients that aren't taking it or are on subtherapeutic doses. I never go above 400. A patient who's subtherapeutic on 400 is probably a patient who's forgetting to take it. So at Hopkins, 500 or below is subtherapeutic. Probably 500 to about 1,500 is therapeutic, but Max Koenig and I recently presented at the ACR meeting that you probably need to be around 1,000 to have the thrombosis prevention benefit. Now, when you're getting above 1,500 all the time, those are patients who are too high, and those are patients that I would want to get down. But I don't want to make these decisions based on one level. I want to base them on a series. So I may do this, sequentially in some patients. And maybe you should check every time a patient has a flare, because we know that many flares are induced by non-adherence.
Thank you. That's great. And is there any chance that subtherapeutic levels of hydroxychloroquine signal anything else but non-compliance?
There might be genetic differences in metabolism, but they don't seem to affect hydroxychloroquine blood levels very much. Just by teaching patients how important it was to be adherent, one of our fellows, Laura Durkhan, was able to show by the third visit nearly everybody who'd been subtherapeutic became therapeutic, which makes it very unlikely that genetic polymorphisms are affecting those low-level patients.
Thank you. Dr. Sio, do you have a question or should I continue?
Yeah. Michelle, there was a few questions about your thoughts on the role of rituximab for the treatment of lupus or lupus nephritis.
I don't think rituximab is going to remain part of rescue treatment. So remember, only 50% of patients who start on mycophenolate have responded by 1 year. And so now I think quite often people turn to rituximab. I might have been more likely to add tacrolimus. But remember, we're going to have better players. We're going to have voclosporin. We're hopefully going to have obinutuzumab in a couple years after obinutuzumab completes a phase 3. So I think rituximab for lupus nephritis may be part of our past.
And Michelle, there was another question about what recommendations do you give patients specifically about sunscreen, SPF, particular brands that you think are particularly effective?
We would like patients to pick a brand that blocks both UVA and UVB. Neutrogena, for example, has brands that do that. There are other brands available in Europe. So it's important for the patient to read the level. Now, of course, there's controversy about how good the FDA grading with SPF really is. But I tell patients, go for the SPF 100. Go for what appears to be the most powerful.
Understand. Now, some questions that are coming in are asking about the low-dose steroids that some patients with lupus are stuck on for a long time despite standard of care treatment. How do you usually approach those given the toxicity of even low doses of steroids?
I have learned to be accepting of 5 milligrams or less because so many patients tell me they need that to manage their morning arthralgias. But it is absolutely correct that even those low doses are going to increase things like cataracts and osteoporosis. You might want to consider going from 5 milligrams to 4 milligrams for 3 months, for example. Sometimes you can get people a little bit lower with that very slow kind of approach to allow recovery from any kind of underlying adrenal insufficiency. But in some patients, you just can't taper with our current armamentarium.
And with that, we are at the end of the hour. So Michelle, on behalf of the American College of Rheumatology, I want to thank you so much for this excellent talk. Everyone, thank you for joining us. Hag Pesach Sameach, or Happy Easter for those of you who celebrate. And we'll all see you next week.
Thank you.